Okay, so central lines. So central lines are, there's many different types. So we need to be able to differentiate between the central lines, and we need to be able to have a idea about, the length of time they can be in, and be able to identify what kind of lines they are. So when you're in clinical, please, talk to your clinical instructor to find all the lines on the floor. So you can feel what a porter cath feels like. You can feel what a permacath feels like. You feel what a vas cath feels like. Identify a triple lumen, identify a PICC line. So you want to be able to recognize those, A, on assessment, but also B, what those different things look like. Okay, so this person right here looks like they're manipulating a triple lumen catheter, and it's just a fancy way of saying it has 3 lumens, has a triple lumen. Okay, and we'll talk about the maintenance of these as well. All right, so the maintenance is we don't want any kind of infection getting into the line, right? So there's certain things we do, like we scrub the hub multiple times, right? To make sure that bacteria doesn't get in. We change these little caps even. And the central line itself, every single day we assess, does the patient need plastic in them, right? So do they need a Foley catheter? Do they need a ventilator? Do they need a triple lumen catheter? Is there a reason for the triple lumen catheter? So those are what? Not causes, but indications. If you're making a chart, right? What are the indications for this line? Do they need this central line or not? Okay, and then also we talk about the dressing change. The dressing needs to be done sterilely, not non-sterilely, or what's another word for non-sterile application or non-sterile procedure. What's that called? Septic or aseptic? Aseptic. Septic means you did dirty, and you spit on, and then you slap the dressing on like a boy handshake in the morning. All right. Anyways, that's the idea. It needs to be done sterilely, and we'll talk about the dressings, and there's cool things they've done to make sure that we are not getting central line associated bloodstream infections, which are CLABSIs. You may hear that word thrown around, CLABSI. There's CLABSI bundles of care that we do to prevent CLABSIs, right? So these are what? These are complications of this disease process, and this disease process is central lines, right? So you're making a table, again, it's indications, symptoms, not really symptoms, but it's like identification. Is this a central line or not? Or is this a permacath or a vas cath? Is this a portacath or a Grosjean catheter, right? So that's identification, almost like EKGs, right? What is this central line, and what are you gonna do about it, right? What are the reasons why you have it there? What are the indications for it? What are the causes of this central line, right? So that's the idea. All right, so types of central lines. So here's our what? How many lumens does this have? 1, 2, 3. It's called a triple lumen catheter, or a TLC, triple lumen catheter, not tender loving care, but triple lumen catheter. And it usually gets, that's the word on the street. They just call it a TLC or a triple lumen catheter. It's like, well, that doesn't tell me it's the central line, does it? It doesn't really, but it just has 3 lumens. I guess it was really cool in the 70s when it came out, and there's like triple lumen. Look at that, 3 lumens, right? But it's stuck. So it's a central venous catheter, a CVC, a central venous catheter. And a lot of these are central venous catheters, but TLC describes it, right? And we got peripherally inserted central catheters. So those are called PICCs. That's what PICC stands for, peripherally inserted central catheter. Why is it called peripherally inserted? Because it is peripherally inserted, right? So where is it? What is peripheral? It's outside of this range right here, right? So here is peripherally inserted, and watch it go up. Let's put a little highlighter on here, right? So the PICC line comes in, and it goes right there. Stops right above the what atrium? The right atrium, right? And if you go too far, you can go all the way and tickle the ventricles. You tickle the ventricles, that's called VTAC, right? So they go into VTAC, which if it's in too deep, right? So how do they know they're in the right place? When they put the PICC line in, there's actually a little electrode on the end of it. And when the electrodes that are on the chest are just fancy magnets, right? They're not even fancy, they're just a positive charge, positive end of an electrode. And when the heart depolarizes, right, that's just a wave of positive electricity, it makes that whoop, little bump, P wave, another big bump, QRS. Why is it bigger than the P wave? Because the ventricles are bigger than the atria, right? So they can do that. They can put they have little electrodes they're going to put inside of the atria, and it should be above the right atrium. It should be perfect. It should be nice and peaked, right there. If they've gone below it, now it's going to be negative deflected, which is not what we want. Okay, is that gonna be on the test? No, it's just a cool fact. All right, cool story, bro. All right, so these temporary catheters, these central catheters can be placed temporarily, like 21 days usually are for most of these. And we'll describe the exceptions. But these guys are placed at the bedside, and they're placed as a as a sterile procedure, right? Because if we're worried about scrubbing the hub and doing a sterile dressing, all those things, and you imagine it's being put under the most sterile of processes as possible, kind of like Foley catheters. You want to put them in sterilely, right? So they don't get a infection. What's that called? We have an infection of a Foley catheter. It's called a CAUTI, a catheter-associated urinary tract infection, right? So PICC lines are one of our central lines that can be inserted peripherally. The nurses can be trained to do this. Doctors used to do it all the time, but then it takes a lot of time, like 20, 30 minutes to get it done. And they were reluctant to give it to the nurses because they couldn't bill for it. So now the PICC line nurses are employees of the hospital, and they can then put it under, so the doctors gave up that chance to bill for this piece, okay? And then central venous catheters, such as a triple lumen catheter. That's just a routine catheter that we put in that we can give medications through, right? So we can give medications through this triple lumen catheter, and they kind of pop out at different spots. So sometimes you give medication via this port right here, and it goes all the way and comes out the end, right? It's called the distal port. So you'll see written on it distal or proximal. So a proximal port would mean we come out all the way just right there. I did change colors, but that did not work. So that's the one I meant, okay? So it comes out, but this is still inside the patient. So it's 3 separate channels. So our medications are not mixing, right? So they come out at different parts on the catheter, 3 different parts, right? For our triple lumen catheters. Are there such thing as double lumens? Yes. Single lumens? Yes. Okay? And these are inserted peripherally? No. If they're inserted peripherally, they'd be called triple lumen peripheral inserted central catheters or PICC lines, right? These guys are inserted centrally. They're inserted in a central vein of some sort. Okay, what's a central vein? It's between the axilla, basically, right, in the torso of some sort, or in the femoral area. So we can insert it femorally down here. We can just make it lighter there. We can insert it femorally down here. We can insert it jugular in the neck, or we can insert in the subclavian artery or vein. Where are these going? These are going in veins. All medications are always given via veins. There are very rare exceptions where you give something arterial or intra-arterial. All right. So triple lumen catheter, peripherally inserted central catheter, they're all going to be ending up in the central cavity and for medication administration of some sort. And we'll talk about the reasons why you give these. A PA catheter, you'll talk in a lot more detail in MedSurg03. So PA catheter is, you thought a triple lumen catheter was cool. A PA catheter has all the lumens, right? It has like 5, 6 lumens sometimes. And it's a whole tangled mess you have to deal with to get organized, right? It has a proximal port, a distal port. It has a pacemaker port. It has a port for measuring the temperature inside the chest. It has a port for medication administration for us. Another ports for measuring hemodynamics, measuring the pressures inside the chest. Okay, so PA catheter we'll talk about more in MedSurg03. Right? It also has a nickname of Swan-Ganz. Those are the 2 doctors that discovered it in the 60s, Dr. Swans and Dr. Ganz. All right, so it's called a Swan-Ganz PA catheter, or pulmonary artery catheter. So our PICC line and our central line, our triple lumen catheter ended up right above the right atrium. The PA catheter goes through the right atrium, through the right ventricle, and goes right back up into the PA pulmonary artery. That's why it gets its name, a PA catheter. All right, VASCath. So VASCath and PermaCath are the names that get thrown around for dialysis catheters. So you have to know which one is temporary and which one is permanent. Which one do you think is permanent? The one that's called PermaCath, right? The permanent catheter, the guy's named PermaCath, right? That guy is used for, that is done, oops, shoot, I'm gonna go to the next slide. I want to, oh, no. Didn't get saved. Anyways, I can't go back in time, otherwise I have to say the whole thing over again. But you notice there's VASCath on the top and PermaCath at the bottom. And those guys are different types of dialysis catheters, right? One is temporary, one is permanent. One can be in for 3 to 6 months. One can be in for like 21 days on average, right? And the other thing we pointed out there was IOs, intraosseous. It looks like a gun, and that gun gets injected into the bone, and you just do a little bit of light drilling at the bedside, right? And the nurses can be trained to do this. We do this in the ICU all the time, okay? You just zzz, and you're done. Your IV's in. It's a lot easier than a peripheral IV start, right? So that's a temporary access. That's only good for 24 hours.
Do you remove any skin? Or you just go straight
No,
through
straight through the skin.
everything's
Okay. Yes, your intraosseous here, 24 hours, right? Why is it only 24 hours? Because you're now in the bone. You have a direct line to the bone. You can get a bone infection. All right, what's that called when you have a bone infection? Osteomyelitis, right? So osteomyelitis, if that's in for too long, all right? These are the sites. You don't have to know the sites. You just have to know that it goes in a bone, okay? And then I think the other thing I didn't point out was intra-arterial catheter, or a arterial line. So arterial lines are just they are considered central catheters, but they can be inserted in the radial artery, which is not like between the axilla, right? And are you going to give medications to these? No. And you'll talk more about arterial lines in MedSurg03 and how they work and what they look like, what the waveforms look like. That's more MedSurg03. Okay, but our job is to know what are the reasons for these, and then we'll talk about the next slide. I believe the next slide where we talk about the why you would have a PICC line, why not just use a peripheral IV. Okay, and on the previous slide we talked about tunneled versus non-tunneled catheters. They're separated out, right? Because which ones are more permanent, if they're tunneled or non-tunneled? So tunneled means that they've gone through the skin and they've tunneled in, and then they drop into the vein. And we'll point that out, especially when we look at permacast versus vascast. You actually feel it under the skin, under the subcutaneous tissue. Okay, so peripheral IVs. So you'll learn how to do peripheral IVs this semester. Okay, are peripheral IVs central lines? No, right? There's such things as a peripherally inserted central catheter, but that's a whole procedure. It takes 20, 30 minutes where every patient's all sterilely draped and it's put in and it's going to end above the heart. It's about this long. It's about 30 to 50 centimeters, right? Whereas a peripheral IV, if you've ever seen one, is 2 inches tops. Okay, so peripheral IVs, they can stay in about 3 to 5 days. Really can stay in as long as you want, as long as you take good care of it. But if it's coming loose, really this should be changed to, you don't want to just change the dressing on a peripheral IV. You just put another peripheral IV in, okay? But you do change dressings on that PICC line because that took a lot of effort to put in. And you have to change that dressing very, very sterilely as well, okay? So peripheral IVs, they can be placed with an ultrasound, right? So the nurses can get trained to do ultrasound guided IVs, where they use the ultrasound and they can see the vessel and they can put the needle in the vessel and then withdraw the needle and the catheter remains, the plastic catheter remains, right? And where do you put peripheral IVs in? It's anywhere, and it should be an arm. I mean, you've probably seen them on a foot, but that's not ideal. The arm is ideal and it should go proximal to distal. What does that mean, proximal to distal? Should go from the fingertips. You might see a peripheral IV in the pinky, right? That's legal. You can do that, right? And it goes all the way up into sometimes you'll see a peripheral IV on a breast tissue, but usually you'll stop at the axilla, right? You stop at the upper arm. So you can put peripheral IVs all the way up, unless they have what going on in that arm? They have something going on, right? They have cellulitis. What is cellulitis? An inflammation of the skin, right? So you got cellulitis, you can add that there. You got cellulitis, you got an infection. You're not going to put a line through an infection, through an infectious source, right? A mastectomy on one side, why don't you do on the same side as mastectomy? Because of lymph, I heard, are they right? So what does lymph have to do with this at all? What's the lymph story? What is lymph? Lymph is the garbage men of your body, right? They take up all the extra garbage and extra fluid that accumulates in interstitial spaces outside the veins and arteries, and it picks it up and it dumps it right back into the venous system up top in the subclavians, right? So it's like if your garbage doesn't come, right, because you don't have garbage service to your area, that area is going to get full of fluid and full of junk, right? So if you put a peripheral IV on one side and it infiltrates, right, then that's going to cause a lot of problems. Okay, so people have mastectomies, they take out the lymph nodes on that, usually the axilla. Okay, so they can't drain properly if anything happens down there. Okay, a dialysis access site. So there are permanent dialysis access sites called AV fistulas and AV grafts. We'll talk about those more in renal, but those are permanent things you can feel and listen to, that are usually placed in the forearms. And this, for almost the same reason, you don't want to be putting a catheter into an area that's been impaired, but also you're going to get a really, really high flow through that. You're not going to be able to really give medications through it. Okay. And what is hemipheresis? What is it? What's a hemi? Let's do some with cars, I think. But a hemi is half, right? So half is paralyzed. Half their body's paralyzed. You probably don't want to put it in the arm that's no good. Why don't you want to put it in the arm that's no good? Back to the story of the lymph, right? What moves fluid is muscle contractions, right? If they're paralyzed on that side, the muscles are not going to contract, and you're going to get the fluid to build up, and you can have problems there. Okay, so complications of a peripheral IV are phlebitis. What is phlebitis? What's a phleb? What's a phlebotomist? Someone that deals with veins, right? So the vein is inflamed. So how you know you have phlebitis? The vein literally looks like it's on fire, right? So it's on the outside of the skin, you can see it light up with redness, right? And what is infiltration? That's where the medication has made its way outside the vein, and it's now irritating the tissue around it. Not just the vein is inflamed, where you can track it up, but the whole area looks inflamed. It might even be swollen with the medication there. Okay, it might even necrose, and they can get gangrene. So it depends on the medication. That's an indication for a central line, right? We don't want that to happen. So we say, hey, you're on a medication that can necrose your tissues and if it comes out of the vein. So we should put you on a central line to prevent that, okay? And then bloodstream infections. It's extremely rare. I'm not sure I've seen one at all in like 15 years, right, of a peripheral IV causing a bloodstream infection. But we still use little chlorhexidine. And do we put a peripheral IV in sterilely or aseptically? It's aseptic, right? We just throw it in, right? You might have even gone to the ER and saw them do nothing, right? You saw them use a finger that's been, not a finger, but a gloved finger with where you can see their finger and they're feeling the site, right? And that's as aseptic as you can get, okay? So the duration is about 3 to 5 days, right? You can put it up to 14 days, but really, as long as you do as much care of that line as possible, it's going to last, okay? And again, ultrasound guided are great because you can get deeper veins, and also it can stay in for longer, usually up to the 14 days, right? And then what's the reason why you need peripheral IVs? It's a immediate IV access for non-vesicants. What is a vesicant? A vesicant is something that will irritate and necrose the tissue if it gets out of the vein, okay? It usually can eat through the vein walls and then make its way into the surrounding tissue, okay? So we'll talk about vesicants on another slide. We describe what they look like and some examples of them, okay? 900 milliosmoles is a example of that. We'll talk about that, okay? And then midline catheters. Midline catheters are just peripheral IVs that are like 10 centimeters. They're just longer. They're not PICC lines, right? They are inserted peripherally, just like PICC lines are, but instead of being like 30 to 40 centimeters, they are 10 centimeters. They don't make it past the axilla. They're just sitting there in the upper arm, right? So midline catheter is the same as a peripheral IV, except it's inserted sterilely, okay? And it's in what location? It's in the upper arm, okay? Without circulatory impairment. So they have something wrong with the arm. It's not good to put something in that arm. A PICC line, peripheral line, midline catheter, or a ultrasound-guided IV catheter is not going to be put in an arm that has what? Has cellulitis, mastectomy, it has lymph node problems, they have whatever's wrong in that arm, you're not going to use it, okay? It's really now time to probably use the other arm, or maybe they need a central line, okay? So midline catheter is usually about 20 days on average, right? But they can last longer as long as you take good care of it. Much lower rates of phlebitis, but you're going to be at risk for DVTs. What's a DVT? It's a deep vein thrombosis. It's a catheter that's long and it's foreign, right? Remember, every day you want to try to get plastic out of the patient if they don't need it. If it's there, it can cause problems. And one of the problems that midline catheters can do, as well as PICC lines, right, same as above, has a DVT risk. So you have someone with a long-term PICC line, they come in with a clot in their upper arm. How do you know someone has a DVT? In their leg or their arm? You do a Homan sign? No, Homan sign is no better than a coin flip. Right? It's like 40% accurate. All right, so you can flip a coin, and then they can tell you more information than a Homan sign. All right, so that means, how do you know someone has a DVT then? So there's 3 things that really clue you in. They got swelling, they got redness, and it hurts, right? So pain, redness, and swelling, those 3 things together, like all those, like almost like a 90% chance you got a DVT, okay? Especially if it's not the other side. If both sides are there, it's like you could have a DVT on both sides, but you just say, hey, did you have a midline there before? Or did you have a PICC line there before? That's the reason they might have a DVT. And we'll talk more about DVTs in exam 2 and what you do about it, okay? But also not for CKD patients. What does CKD stand for? Chronic kidney disease. So if someone has kidney disease, They might need a vas cath or permacath in the future, but also they might need an AV fistula in the future or an AV graft in the future in the lower forearm. So if you mess up the upper arm because you had a PICC line or midline there, now you can't use the lower forearm, right? It's because it has impaired flow now. All right, so you don't want to use, if they have a history of, or they have CKD right now or a history of CKD, then they might need dialysis in the future. Usually we get the nephrologist, the kidney doctor's blessing to put that midline in or PICC line in if they need it, right? Otherwise they say, can't you try a central line? So then we might need to do a central line, okay? So midline catheters are usually for a longer stay in the hospital. Very, very difficult access. It's done via ultrasound, just like a PICC line done with ultrasound. And it is, it's not as permanent as a PICC line, right? It's usually about 21 days or so. Right? It's just a longer peripheral IV, right? And can vesicants be given through it? Not really. Usually if the vesicants are given temporarily, we might give it a pass. But if we're on that vesicant for a long time, or we really need to switch over to a PICC line or a central line, right? Well, I thought PICC line was a central line. It is, but it's just a peripherally inserted one. Okay, and how else is PICC line different? It can last for 6 to 12 months even with good care. Okay, so it's in there for a long time. It's inserted where? Peripherally, right, into the upper arm, and it terminates at the SBC atrial junction, which is just right above the right atrium. Okay, and it's placed at the bedside. We confirm it with an EKG or a chest X-ray. Usually EKG is the standard right now. Okay. And then we go to central catheters. So we have non-tunnel catheters and tunnel catheters. Which ones are more permanent? The tunnel ones. That's why the dialysis catheter can be done temporarily or permanently. And permacaths are tunnel catheters. Okay. So other examples of non-tunnel catheters are our triple lumen catheters, right? There's many others out there that are double lumen, single lumen, bigger size, smaller size, but really triple lumen catheter is the most common one you'll see. Okay. And other examples of non-tunnel catheters, we got a PA catheter, which we'll talk about Med-Surg, and then a dialysis catheter. So, and what kind of dialysis catheter? A temporary one. They call it a vas cath, which is not very creative because vas cath stands for vascular catheter. It's like, cool. That doesn't tell me it's dialysis or not, right? But you'll hear the nurses say vas cath or permacath. And you'll hear the nurses also say vas cath for permacath. And you want to be accurate to know that is this a vas cath or permacath, right? Because there's two different things you have to do about it. Okay. Anyway, these guys are put via central vein, the jugular vein, subclavian vein, right, and also the femoral vein. And it should be when these central catheters are inserted, the usual order of operations is to put it in the place that's not going to get infected, right? So the subclavian vein is actually the best vein to be inserted because when you have patients unresponsive and they could be drooling onto their jugulars, they can be drooling onto their neck. It's really hard to drool onto your clavicle. I mean, there's some talented people out there. But femoral is the worst one to put in because there's all kinds of stuff going down there. And also if people stool, they're incontinent. It's a bad situation. It's especially bad if they're obese. Obesity has higher rates of fungal infections, higher rate of cellulitis down there. So that's the worst thing. It's acceptable in patients that have a good BMI, that are not obese. But we definitely want to avoid it. And why do I tell you this? Because as a nurse, you have to advocate. The doctor come in, we're going to put a femoral line. Now that's easy. But sir, their BMI is 45, and they have look at all the cellulitis and fungal infection. They're getting Candida 3 times, or not Candida. They're getting nystatin 3 times a day. So they probably shouldn't be using that site, right? So you have to advocate for a better site. All right. What are the complications when you put in these central lines? And we'll talk about these as well. You get a pneumothorax, a PTX stands for pneumothorax, or a hemothorax, that's blood inside the lungs, right? Or air inside the thoracic cavity. And that's a significant complication. So every time we put in a central line, that's in the upper cavity, right? Not a femoral line. If you put a femoral line in, there's no reason to do an X-ray. You're way too far away from the thorax, right? But if you're messing around anywhere in the thorax, right? So the neck's not in the thorax, but it's going to end up in the thorax, right? We have to then, the complication is that the lung can pop and the lung can collapse, right? Or you can bleed profusely into the lungs, okay? And then hemorrhage itself, so you can hemorrhage at the jugular site. They can hit the carotid instead of the jugular vein, right? So that can cause excessive bleeding, and you'll notice that at the site, right? And again, we can puncture the artery that's nearby, right? Even the femoral site, there's an artery right next to it, Okay, there's a vein and artery right next to each other down in the femoral triangle down there where they insert it. Arrhythmias can happen. Why would an arrhythmia happen? They place it too deep and it's going to go too far and it's going to tickle what? It's going to tickle the ventricles, right? Or tickle the atria even. Why do you have so many PACs? Well, because you're poking the atria. That's why they have premature atrial contractions, right? And then what? Those are like early signs, like immediate signs you'll see in the first 24 hours. But late signs are after like 5 days, 7 days, 10 days, you might start seeing signs of a CLABSI or a BSI, is just a bloodstream infection. This a central line associated bloodstream infection. And then it's like, we're not done. When you take it out, you can have complications, right? So inserting it has complications. Use of it can have complications if the nurse isn't using as a good technique as possible. That can cause infections. And then removing the catheters. So when you remove the catheter, they can have air emboli, and we'll talk about what that looks like. And the catheter itself can fracture, and some of it can remain behind, and that's not good. Okay, so these guys are usually about 21 days also. Okay, and we have what's called CHG impregnated catheters, which reduce bloodstream infections, and we'll learn CHG stands for chlorhexidine gluconate, and it's better than alcohol. So we used to be iodine was the cool thing to do for a long time, and then it was alcohol, like 70% alcohol, like Purell, and then it was now chlorhexidine. It's a better antiseptic. Okay, so again, we need a chest X-ray. Do you need a chest X-ray for a femoral line? No, because the chest X-ray is not going to find it, but also the central lines are only like 20 centimeters, and from the groin to your lungs, that's a lot more than 20 centimeters. Right? Again, we mentioned the lumens, the little ports exit at different spots. Right? And you can assess hemodynamics. So you can assess different pressures inside the chest and the venous system with these catheters. You'll talk more about those in MedSurg03. Okay? And then we have tunnel catheters. Tunnel catheters are usually placed up top, right? And in the subclavian or jugular vein. And these guys are going to be in there for a long time. And they are sent in underneath the skin, and then they make a turn into the target vein. And these guys can be more than a year if they're taken care of well. Okay, so again, these are for chronic therapy. All right, and these ones need to not clot off because the lumens of the catheter might clot off. Right, so we can prevent that in the hospital setting by using good technique, by make sure we're flushing it often, right, at least twice a day, and using the right way to flush. But these guys, when they go home, who's going to flush it at home? So we have to do what's called packing of the ports. So the ports need to be heparinized, or they need to be anticoagulated, because we have another option. We have citrate as another option to anticoagulate that port so it doesn't clot off. They don't need to go through the procedure again, because this procedure is not done at the bedside. This procedure is done in the cath lab, or procedure is done in the OR even to get it done. And that's pretty expensive. They can charge like 10 to 15K to get it done. All right. So and then other plastic, we're not going to spend too much time on these guys, but these guys are other options that need our attention. So when you look at a patient, like, what's this? And you can refer back to this, oh, that's an IO. Or you can say, oh, that's an A line, actually. And you probably won't see an A line until MedSurg03 when we come to the ICU.
Do you still for a test purposes want us to know the arterial line?
Arterial lines, no, not for the test. We're not testing on that. We're testing you on these central lines up top above the yellow, right? And can you recognize, again, the two different dialysis catheters? That's a very good test question. It's like, do you know which one's permanent, right? Can you recognize which one's permanent? If I show you a picture of a dialysis catheter, can you see if it's a permacath or vascath? All right, so these are non-tunneled central line insertions. So with a vascath, with a triple lumen catheter, or the PA catheter even, these are all inserted sterilely. So you can see how sterile it is, right? They put a huge sterile drape on the patient. They use an ultrasound there, okay? The provider wears a little cap, right? He wears a mask, right? We wear sterile gowns. The whole thing is done sterilely. It's a whole to-do, right? And if you've not put a peripheral IV in yet, this is just like a peripheral IV with one extra step. It's really not incredibly complicated, but it is a extra where you put the peripheral IV has a needle with plastic around it. You put the needle in, and the plastic goes with it, and you take the needle away, and the plastic remains behind, and now you have an IV access, right? Well, this you actually you cut the skin, you put a dilator in there to get that big catheter all the way through all that tissue. Okay, it's called the Seldinger technique, and then we adapted that with peripheral IVs. And we have, it's called an over-the-needle exchange, right? You put the needle in, plastic remains behind. You know, back in the day, there was real needles that left behind. In the 50s and 40s, it was like an actual needle that was there the whole time, right? But now we have this technique, okay? So again, it's a sterile technique, and you use CHG prep. What does CHG stand for? Chlorhexidine gluconate. It's an important piece of the preparation and also our maintenance when we change the dressing in the future. Okay, so full patient drape, full gown. Everyone in the room wears a mask. That used to be a problem. That's not a problem now, but it used to be a problem before COVID. All right, ultrasound guidance so is the best thing. That way you don't poke the artery that's right next to it, right? So that lets you see exactly where you're going to go, because an artery has a thicker wall to it, and it pulsatiles. So put little pulsatile markings there. It pulsates with every contraction of the heart, right? Whereas a vein, it is completely collapsible. You can collapse it all the way down and make it disappear, right? So that's how they know they're going to the right site, right? And what's the best site to use for a central line? That's a subclavian, right? You can use femoral if they have, they're not obese and there's nothing cellulitis-like going on, okay? The jugular can be contaminated. Femoral is the worst. It can be contaminated by stool and urine, and also the skin folds are a warm, moist environment, which bacteria love. Bacteria love warmness, they love moistness, and they love staticness. They love things that don't move. Like when you have a UTI, it's usually because the urine is stagnant, right? What else? So if they do get a femoral line, usually we change it within 24 hours, right? Sometimes the femoral line was placed in an emergency. They had a code blue or they had an arrest. They had to give all these different medications, and now A, they're better and we can just take that line out, or B, they're still sick and we might have to switch it out to a line up top, right? So acute complications, what happens like immediately in the first 24 hours, even like the first hour, is they can get a pneumothorax. That's where the whole lung pops, right? So you notice over here we got lung tissue. It has a little faint grayness to it, whereas over here it's completely black, right? So air is black on X-ray. X-rays are where you shoot beams of X-rays through the patient and it gets absorbed on a plate behind them, right? Bones are going to absorb a lot of it, right? So that's why they're white, right? It's like a ghosted image. And lung tissue has a bunch of air in it, but it also has tissue in it. So it's going to see tissue and really, really dark gray. So if there's a complete pop of the lungs, you're going to see complete blackness on that side. Okay. So anyway, so pneumothorax is possible. You can have a hemothorax even. So how do we know if someone has a pneumothorax? There's signs you can do. You can listen and say, oh, I don't hear anything on this side. But the other thing is an X-ray. That's needed to make sure there's nothing wrong. Okay. The other reason why you get an X-ray is to make sure it's going to the right place. Make sure it's not too deep. Make sure it's not going to the wrong way. Okay. So you see that catheter there, right? The catheter is put in. Where is this catheter inserted? Jugular, and it's supposed to go to the right atrium, but it went off to the side, right? So what else? So we can do, chest X-ray should be identify where it's at, and if we go in too far, we can start causing, what's this rhythm here? It's a wide complex tachycardia, which is usually what until proven otherwise? It's usually VTach, right? We can have hematoma and bleeding at the insertion site because we have to poke a needle there too. We might go too hard. There might be some air done on insertion. We might have to apply some pressure to make sure it doesn't get worse, right? The catheter might, again, go to the wrong side. And then air embolism on insertion and also on removal. So we'll talk about air embolism. Okay. And then what else? Arrhythmias we talked about. And then late symptoms are a CLABSI, especially if it's in for a long time. Okay, it's not in a good spot. So that's exactly how you insert a central line. And we have to be alert to these symptoms and complications. Okay. All right, so central line removal. As we mentioned, you have problems, complications with central lines when they're inserted and when they're there for a long time. What's the complication that happens if they're there for a long time? What is it? A CLABSI, right, or a central line associated bloodstream infection. This is a complication when you remove it, right? There's complications also on removal. So it's important we're aware of these things because there's a lot of complications. They're great, but there's a lot of complications that can arise, all right? So before you remove the catheter, we're going to check the labs that assess how well someone's bleeding, how someone will clot, all right? And that's where the INR will help you. INR is a blood test we can do to assess if they are at risk for bleeding or not, right? And then platelets. So platelets are needed for a clot, right? Two things you need for a clot. You need a fibrin mesh, right? And you need the actual platelets themselves, little platelets in there too. And then now you got a clot, right? The fibrin mesh is made by the coag cascade, and the other little things that get trapped are your platelets, right? So we got to see if those things are good. If they're not, it's probably not a great time to remove the line. We got to make sure, we might have to even get a blood transfusion of platelets if we need to, all right? So they should be positioned when you're taking out the line. The PICC lines should be done with the head bed elevated. Otherwise, we should do a Trendelenburg. What is Trendelenburg? This is Trendelenburg. You can see all the blood is going all the way down to the neck, so it's impossible for air to get into the neck, right? Or into the subclavian vein. So you're laying them flat, and you're using the patient's own gravity and blood to prevent air from trying to get in. Because what does air want to do? It wants to get in as soon as much as possible. It's going to try to make its way through into that vein. Okay, and what if that happens? Well, now the air bubble from the jugular makes its way down. Now they have this huge air bubble inside your heart, and that's not good. Now that's going to impede the flow of blood, right? So why can't your blood flow, overcome that? Well, it can't if it's on the right side, which is a lower pressure system, right? So we can avoid air embolism by keeping them, what is it, reverse Trendelenburg or Trendelenburg? It's reverse Trendelenburg, so it prevents the air from getting into that chest. Okay, so we're going to remove sutures. There's sutures that are keep this in place because we don't want this to just pull out. You don't want the patients to pull out their central line. That's going to be a huge hole in the neck. They can A, get air embolism, but also B, it can bleed out everywhere. That's not good. So that's why it's sutured in place. So when you take this out, you use little sutures to take it out. And then we avoid air embolism by positioning them correctly, right? So then what happens, how do you know someone's going to get, when should you pull it out? It's usually done at end inspiration. So that's with the respiratory hemodynamics, when you breathe in and exhale, there are certain times where air wants to be drawn into the chest, right? There are certain times where the thorax is under low pressure or high pressure, right? And everything in the universe goes where? From high to low or low to high? Everything in the universe wants to go from high something to low something, where there's a lot of water to where there's low water, which is low concentration to high concentration. But everything wants to go from high sodium to low sodium, high potassium to low potassium, high glucose to low glucose. It wants to go from a lot of pressure to low pressure, high gravity to low gravity, right? So when you when you inhale, you are bringing your diaphragm down, right? And then we know by physics and the law of Poussey that when you have it wasn't Poussey's law. Why'd you correct me? It's whose law is it? Laplace, right? So anyways, Laplace's law says that when your diaphragm goes down, you make a container have a bigger volume, the pressure gets lower. So then now air gets drawn into it from the outside into the inside. So when should we pull the line? When they are completely what? End inspiration, when they're done. Okay. So anyways, signs and symptoms of an air embolism is they have sudden shortness of breath. They can't catch their breath. They're in a lot of distress, right? So how do you fix this? You put them on the left side. You make sure the bubble is just like any kind of other container. Put the bubble to the top. That's all you do. And put them upside down so the bubble stays in the where? In the right atrium. We don't want that bubble making its way to the ventricle and going to the lungs. Okay? So we just use the effect of gravity to keep that bubble where it needs to be. Okay? Give oxygen because they're probably going to be in a lot of distress. We're not going to sit the patient up or raise the head of the bed at this point. All right, but if none of that happened, you just apply a sterile gauze and remove it slowly and apply pressure for 5 minutes to 10 minutes. If they have a really high risk of bleeding, probably be a longer time, but otherwise it's usually 5 minutes for these vessels, right? And also femoral would be another reason why you might hold it for 10 minutes. Whereas if it's subclavian or jugular in the upper neck or the clavicle region, you just hold it for 5 minutes and that should be good, okay? If you don't hold it long enough, blood can accumulate under the skin, and what's that called? Is it called an ecchymosis? No, an ecchymosis is a fancy word for a bruise, right? So someone has a bruise, that's an ecchymosis, right? You talk to your 5-year-old and say, hey, why are you so ecchymotic? What happened? What happened right here in your knee, right? Why do you have a knee ecchymosis, right? Or subpatellar ecchymosis, right? So that is just a bruise. A hematoma is a collection of blood underneath the skin, right? So you look at you pull the patient's neckline and you come back in 10 minutes and their neck's like huge. It's like, well, shoot, you got a hematoma under your skin, okay? So you apply the dressing, and we have something called a pressure dressing where you apply tape and that's going to go, that's going to apply a little bit of extra pressure after you're done holding manual pressure. And then they should be, for 15 to 30 minutes, they should, they should remain laying flat so that we don't have any kind of untoward side effects. For femoral, you don't want them to sit up right away, otherwise that can manipulate the site, manipulate the pressure that you're just holding. So usually for 1 hour or so, they're going to be laying flat. Okay. And then also, when we pull out the catheter, we want to make sure that the catheter is intact, that the end of the catheter is there. So this is what the end of the catheter looks like. If you pull it out and there's no end, that's a problem. Okay. So it's pretty much the same thing. We got to put them on their left side, and they're going to be upside down until we can figure it out. All right, so hemodialysis catheters. So it's highlighted blue because we highlighted it before on the other slide as well. So hemodialysis catheters are battery running low. So let's plug in over here. So hemodialysis catheters can be temporary or they can be permanent. Okay, so the temporary ones are non-tunneled or tunneled? Non-tunneled are temporary. Okay, so temporary catheters are going to be good for like 21 days on average, and then we need to then pull them out afterwards, right? If they don't need it. If they still need a dialysis access, they still need a vas cath of some sort, then we have to switch them over to a what kind of permanent catheter? Permacath, right? So permacaths are the tunneled ones, right? So we got permacaths and vas caths, right? Which one's placed at the bedside? The ones that are tunneled or non-tunneled? So this is an easy chart to make, right? Tunneled, non-tunneled, which ones are which, right? Which ones are permanent, which ones are not, right? So that way you're not getting all confused, because it's an easy question to ask, right? You can ask like 5 different ways, right? Which one of these is more than 21 days? Which one of these is for someone who needs long-term dialysis? Which one of these is for short-term dialysis? And it can be option of tunneled or non-tunneled, right? Or vas cath or permacath. Right, which one is surgically placed? Which one is placed at the bedside, right? So permanent tunnel catheters are usually what's called a bridge, right? Until someone can get a AV fistula or AV graft in their forearm. All right, you can't be in the hospital for 3 months while your fistula matures, right? Like British mature, right? So while your AV fistula or AV graft is ready, right? It's not gonna be ready for a good 2 to 3 months, right? So in the meantime, what are you gonna do? You're gonna keep 2 months is more than 21 days. So we need a permacath in the meantime, okay? And then in emergencies, you can use these other 2 ports, but that's not very frequent, right? Otherwise, it's strictly for hemodialysis. There's even some hospitals have policies where nurses the RNs at the bedside can't touch it. It's only the hemodialysis RNs who do the dialysis that can touch it, okay? So what else? So it can be used for emergencies, but this is a huge, huge lumen. That means if blood's in it, it can easily clot, right? Easily clot off. So we do what's called packing the ports, where you pack it with an anticoagulant so it does not clot off. And you can use it, like the permacath, you can use it for 3 months even if you needed to, right? So how do you use it? After every single session, the hemodialysis nurse is trained, and now you are trained, that you know that you have to, hey, they disconnected. What'd you guys use? Did you use citrate or heparin, right? And the better one to use is citrate. There's something called a heparin allergy that you'll learn about MedSurg02, heparin-induced thrombocytopenia. So it's a complication that can have with heparin. So why even bring that up? Why don't we just do citrate all the time, right? And at Palmdale, at least in the ICU, that's what we do, is we always use citrate, right? So heparin-induced allergy, induced thrombocytopenia is a heparin allergy. All right, so how much do you give for the heparin? If someone already dived into the math homework this week, right? On the port itself, it tells you how much. It says give 1.8 cc's. Give 1.8 cc's in both these lumens. So from this point to this point, all right, from right there to the time it gets to the catheter is 1.8 cc's, right? It's probably a little bit further down. It's probably to the end port where it actually comes out, right? Anyways, that is the idea with the packing of the ports. You don't want it to do what? What will happen if you don't do that? It's going to clot off, and then they have to have another one inserted. We have other things we can do in the meantime. We can try to bust the clot, right? We can give a medication that will dissolve the clot, right? And we'll talk about that on the next page. It's called a thrombolytic, right? Lytic means what? Break apart, and thrombo is what? It's a thrombus. A thrombus is a clot. So it's a medication that busts clots or lyses clots, right? So how much do you give? It's on the lumen, right? If they're not heparinized, they have to use a thrombolytic. So we'll add that here. Thrombolytic. An example of that is TPA. Okay, so how you tell the difference between a tunneled and a non-tunneled catheter? A tunneled catheter is underneath the skin, right? It's under the skin for a portion and then it goes into the vein. It is literally tunneled under the skin. That's why it's called tunneled, right? Whereas a non-tunneled catheter just goes just like a peripheral IV, goes through the skin into the vessel. That's it, right? So over here we have, you can see this guy. Let's see a good example. I think is maybe another slide will have it, but this guy right here. Oh, sorry, right here. All right, this guy goes right into the skin and goes right into the vein. The vein is right underneath it. It's not tunneled first and then drops in. You might get disoriented. Here's the patient's shoulder, right? Here's the patient's chin, mandible, turned off to the side right here. Here's the patient's smile. There's their eyeball and their nose, right? So it's going right into the jugular vein. It is tunneled or non-tunneled? It's not tunneled, right? Whereas a permacath, you can see this permacath right here, is right below the clavicle. It's like, oh, it must be going to subclavian. It's not. It's tunneled underneath. You can actually palpate this, right? You can feel it underneath, and then it's going to drop into the jugular. Okay? You can feel it under the skin, right? If someone asks you if it's a permacath or vascular, say, hold please, let me palpate, right? You can palpate all the way up, and then it drops right in the neck. Okay? So that's a what? Permacath or vascath? This is a permacath, right? Whereas this is tunneled or non-tunneled, vascaths. Non-tunneled, right? So this one guy over here, what's this depicting on the left? That's a tunneled or non-tunneled? That looks tunneled, right? That's a tunneled catheter, therefore it is a tunneled dialysis catheter, therefore it is a which kind? A permacath, right? And what this one right here, what is permacath or vascath? That is tunneled underneath, and then it's inserted. They got a lot of redness there, so that's not good. So that's something to monitor. Okay, this one up top right, what is this catheter right here? That is non-tunneled or tunneled? That is tunneled under the skin. You can see this piece right here is tunneled right there, right? And then it goes into the jugular vein. Okay, there's actually a little cuff right at the insertion site. There's a little cuff right there. There's a cuff right there. There's a little cuff right there. Sorry, a little higher. Little cuff right there, where it's inflated so that the bacteria can't make its way via that tunnel. Okay, there's another way to prevent bacteria from making their way into the body. Okay, so flushing central lines. So you want to flush central lines to prevent them from clotting, right? So flushing every 12 hours usually is routine, right? And how you flush is with a push-pause method. So it's push, push, pause, push, push, pause, or push, pause, push, pause. It's not just one nice continuous flow. It's push, 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 right? And that gets rid of all the little dingleberries that are making their way inside. So little dingleberries will make their way there, and you're like, not today, right? So you're just going to bidet them away. Okay, so that's the idea. Doing the push-pause method. It's like Lamaze, right? So Lamaze is he-he-hoo, right? You use the same thing, okay? It's like, I'm going to use the Lamaze method when I push and get this catheter working again, right? It breaks those microclots, right? That may be forming at the end of the catheter, okay? And you also maintain positive pressure. So when you're clamping it again, so otherwise air can be drawn in. So usually nowadays they have these little caps on the end of the lines, which maintain positive pressure the whole time. That way blood doesn't get sucked back in or air doesn't get sucked back in. It's always has the fluid that you put in there. Okay, these are called claves. They apply positive pressure and allow that pressure to be maintained so the blood doesn't back up into the catheter and then you get a catheter that doesn't work. Okay, and if you didn't use the push-pause method or has been used for a while, it may be clotted off, right? A huge clot can be at the end of the catheter. There's the catheter tip right here at the end on the right. So we have to then break it apart. So if we can't get it dislodged with just regular flushing, we can give alteplase, which is a thrombolytic. It's going to lyse the clot, right? And it basically just dwells in there. You only give enough to stay inside the lumen. We want to give it to the patient, right? That's when patients have strokes, they actually get TPA also, right? But we just want that clot to be stopped right there, right? And that will then eat away at the thrombus, hopefully, okay? Tissue plasminogen activator, or TPA, is ogen. It's the creation of plasmin. So you're giving the precursor to the body's natural plasmin. And plasmin is the body's natural thrombolytic, right? So we're giving that in high concentration via the IV, right? Goes in, and it's going to make a whole bunch of plasmin locally and break that clot, hopefully. Okay, usually 2 hours is good, but it might have to stay there overnight. Okay, and usually they label it with a lot of effort to make sure nobody just gives that TPA IV push, because then you're going to start breaking clots elsewhere and you can make them bleed to death. So that's not good. Okay, and then drawing blood. So if you have to draw blood from the central line, there's a whole procedure here. We're not going to get too into it, and we're not going to test you on drawing blood, but this is the procedure, and you'll learn this also in, unfortunately, they moved this check off to MedSurg02, which doesn't make too much sense if you get taught it right now. But either way, that you can come back to this, is the proper method for doing blood draws out of a central line. Basically, you flush it to make sure it's good, you draw your blood, and then you flush it again, right? Every time a catheter leaves a hub, right, you have to alcohol swab it, right? Because someone in the room might have sneezed, or you may have lost sight of your catheter. It never does, but you're supposed to wipe every single time, right, to make sure there's nothing remaining, right? What else? So the push-pause method is the proper way, and then you see this person's drawing blood out of the lumen there. First off, they flushed it, make sure it's patent, and then they draw the blood back, right? Sometimes a little dingleberry at the end, and you can't draw back the blood because it just sucks, and then your vessel doesn't work that great. So you give a little extra flushes to try to dislodge it. Otherwise, that lumen might not draw blood, but the other one might. Okay. All right, so tunneled catheters. So these are placed surgically, and these last weeks or even to months, up to six months, right? Well, it says 6 years because you could have it in for a long time. Sometimes patients have no other options. They have to get this placed. They had a failed fistula here, a failed fistula there, a failed fistula here, there, and they have to have the permacath. So it's sometimes patients get into that situation, but either way, this is bacteriostatic when we do this. The sub-Q tract, the bacteria cannot make their way through, all right? And the catheters are scored above the cuff so that the tissue will adhere to the catheter. So if you feel the catheter when it's outside the package, it actually feels rough. So the skin will then get into all the little grooves there and be a tight seal onto the catheter, right? Compared to a tunnel catheter, it's just a nice straight shot, right? It's super smooth all the way in, okay? So what are examples of tunneled catheters? Permacaths or vascaths? Permacaths, right? And there's some chemotherapy type tunneled catheters that are used for long-term therapies, such as a portacath. So a portacath is inserted surgically, and it's placed usually on the subclavian vein underneath the clavicle. And when they come to the hospital or they come to their outpatient infusion, we poke it with a special needle called a Huber needle with an umlaut, right? So it has a special needle that goes in at an angle, a little bit of an angle, and then we attach our catheter to it. We aspirate the heparin that's inside, right, or citrate, and then we are good to go to give our medication, okay? So that's the idea of a portacath. And how many times can you poke that with a Huber needle? So here's a little Huber needle here with this little bend. How many times? Up to 2,000 times, right? So you have 2,000 hospitalizations, right? So that's it. It'll be there for a while. And you must heparinize before you take the needle out. Otherwise, you have to poke them again and then apply the heparin, okay? And then what else? Hickman is another type of catheter. That's a long-term tunneled or non-tunneled? It's a tunneled catheter, okay? Hickman catheter, Broviac catheter. Usually Broviacs are used in peds. All right, and then we have Grosjean catheters, which have those positive pressure valves that prevent blood from getting in. And those ones do not need heparinization. So that's something that's different. So that's something that can be tested when it's different, right? So what else? So we have tunneled central lines right here on the top right. You can see this guy is going underneath so it's inflated right there. They call it a Dacron cuff, little cuff that's inflated. And then it's scored so that the tissue will adhere and grow onto the catheter, right? And then it'll make its way drop into the vein up top, into the jugular vein. Okay, so let's see what this video is, because I don't remember.
Here's an HD cath with a Dacron cuff for tunneling. The Dacron cuff is rough on the surface so that when the tissue surrounding this catheter grows, it'll heal with the catheter attached, and basically will be a securement device or a securement, natural biosecurement on its own instead of needing a securement device. Now, until this is fully healed, you need some kind of securement device like a stat lock or secure cath to keep it in place until that area heals over. And after there's good adherence, there's really no need for any sutures, stat lock, or secure cath. It can actually hold it in place pretty well.
All right, so after a while, the sutures will come out, and then that's going to be your own suture. It's really hard to remove one of these. You can't remove it usually on your own. You have to really get in there to get it out. Okay, so we have different catheters here, right? What's this first top left catheter? What kind of catheter is that? It says subclavian, but is it tunneled or non-tunneled? I guess it's a better question. So is it tunneled or non-tunneled? That's non-tunneled. It goes right into the subclavian. What about the next one? That's a PICC line. That is non-tunneled as well. What about this femoral line? Also non-tunneled. What about this one down here? So a Hickman, we know is tunneled, but you can see how it goes underneath the skin first and then drops in, right? And then next guy is a subclavian catheter with a access port. We don't see those as common, but usually, sorry, it's, I'm trying to think of something else. But anyways, there's a portacath, right? So the portacath will sit underneath there, underneath the skin, and then it will make its way into the vessel. Okay. Tunneled, yeah. I mean, it's not really tunneled. I mean, technically, it's technically implanted, right? It's underneath the skin. It's subcutaneous. Okay. All right. So when do you need a central line? What are the what's the needs for it? Well, we described if it's in there for too long, you need it, right? So if it's more than 21 days on average, you probably need a tunneled catheter, right? But when do you need a central line, like acutely, like right now, when do I need to have a triple lumen catheter inserted? When I need like massive fluid, massive blood infusions, right? Someone's hemorrhaging, you need to have that central catheter to provide all those medications and multiple lumens. Usually you're going to be giving more than one medication when someone's super sick, right? You can't get a peripheral IV. We have patients that arrive that are really, really hard sticks, and they can't. Peripheral IVs are just not an option. They might need that, right? It's not because you can have like 5 peripheral IVs as long as none of those peripheral IVs that you have to, none of those medications you give are toxic to the veins, or they are not what a vesicant, right? You can have 5 peripheral IVs. You have 6, 7, 8 peripheral IVs if you wanted to, right? But as soon as you start giving vesicants, or you cannot get a peripheral IV, you probably need a central line. We can try ultrasound guided first to see if that works, right? But if you need a vesicant, we got to skip that step. We're going all the way to using a central line, right? And vasopressors. Vasopressors are vesicants. So if you're giving a vasopressor, what does a vasopressor do? Presses vasos, right? It vasoconstricts, and that's going to do what to your blood pressure? It's going to raise it. So we give vasopressors when patients' blood pressures are low. And sometimes they need really, really high doses, and they need a lot of them sometimes, like 3 or 4 of them infused at the same time. All right. In the ICU, we do hemodynamic monitoring. If anything is a hole in the body, you can get a pressure waveform from it, right? So if you see a pulse ox go up and down, up and down, up and down, right? You can get that from an artery line. You can get that from the PA. You can get that from the right atrium, the left atrium, the bladder pressures. You can get it. You can tap anything and see a pressure and interpret it, right? So these ones, we hook up a little pressure monitoring system to the end of the central line, and we can assess what their venous pressure is, for instance. All right. So then high osmolarity. So what does osmolar mean? Concentration, it's a measure of concentration. So if something is really, really osmolar, that means it has a really, really high concentration. So if you give it to somebody, it's going to pull things that are in low concentration, right? Water always goes from high to low, right? We said everything in the universe goes high to low, right? So there's a lot of water in something, it's low concentration, but it has high water. As you go to a place where there's low water, which has very, very high concentration. Okay, so when it does that, if that's really, really high concentrated, right, it's going to really run out there much more than something else that wasn't as high, right? So the problem is what if it's like super, super high? It's going to start going really fast, and it's going to start tearing through the vessel wall, right, and causing holes and damage to the vessel. So whenever we give something really, really high concentration, we need to make sure that we have a central line, make sure that wall can tolerate not being torn apart. A wall in the pinky is not going to be as great as a wall in the subclavian. It's much, much thicker up top. Okay, so greater than 900 milliosmoles, greater than 20% dextrose, right? Where sodium goes, water follows, and where dextrose goes, water follows, right? So if you have a really, really high concentration of dextrose, that's going to start tearing through those vessel walls if it's not given centrally. Okay, so usually greater than D20. Okay, so you've heard of TPN and PPN, right? So total parenteral nutrition and peripheral parenteral nutrition. The only reason why it's called PPN is because it's given peripherally. Why is it given peripherally? Because the dextrose concentration is less than 20%. If it's 20% or higher, it's called TPN, right? It needs to have a central axis because that TPN not only attracts bacteria, but also it is going to tear apart the vessel walls and cause damage to the vessels and not be a good outcome, okay? And then there's things that are just vesicants in of themselves. It's not because they're high concentration, like a dextrose or something else. It is just literally like an acid that's going to eat away at the vessel wall. So like a vesicant is just going to eat away at the vessel wall, and it's going to cause breakdown of the tissue, and eventually it's going to make its way through into the local tissue, right? So like one of those vasopressors called norepinephrine, they gave it through a thumb right here, right? Give it through a thumb, and then it's a vesicant. It's like, oh, they got it. They got a vessel. It's fine. It flushes good. But the Levophed or the norepinephrine it literally eats away at the lining, and then it eats away into the surrounding tissue. So we progressed to a point of no thumb, right? They took it out after 24 hours, but he was getting a lot of medication through that thumb, right? So it's important that it's going to, and then he had surgery to amputate it, right? So it's important that you have vesicants going through what kind of lines? Central lines, right? Peripheral lines are going to get maybe temporarily for the first 4 hours, 8 hours tops, but really the priority is to get them into it with central access. Okay. All right. So what else? So vasopressors, chemotherapy drugs. We'll talk a lot about chemotherapy in MedSurg02, but there's some chemotherapy drugs that are just they're extremely toxic to the body, and including the veins, right? So it's toxic to cancer cells, but also our own cells. So we have to give those via a central line. Okay. There's some other medications out there that are going to really tear apart the vessels. All right. So emergent meds, again, you can give temporarily, but we really need to proceed and advocate to get a central line. Okay. So such thing as isotonic, hypotonic, and hypertonic solutions, right? That you're studying more with the IV piggyback deal with in the clinical course. But which one of those three is requiring a central line? Isotonic fluids, hypotonic fluids, or hypertonic fluids? So hypertonic fluids mean it is in greater concentration than our serum, right? Our serum is our plasma, what's the concentration of our blood, right? As far as like how, with all the different things that are in there, sodium, glucose, BUN, all these things that hold on to water. What if we were to give something super, super concentrated? It's going to pull all the water from the tissues, and when it does that, it can tear through the vessel walls and cause damage to the veins and lead to infiltration and more problems. Okay, so acutely, these are reasons why we might need these medications. These need a central line. Chronically, there's again antineoplastics, which is a fancy way for saying chemotherapy, right? And of course, hemodialysis. For hemodialysis, that's a reason why we need a catheter for a long period of time. So sometimes you will see infiltration or extravasation, and we'll use it interchangeably, but they technically mean something different. Infiltration means that the vein ruptured, right? The IV was going through that vein, and the vein wall popped, right? And the medication went into the surrounding tissue. It extravasated, right? But it did not cause the thumb to fall off, right? That is extravasation. If a vesicant extravasates, that is called a vesicant, right? So what else to say on that? So vesicants, again, high osmolarity, and also the pH will make it very, very likely to eat away at the vessel walls, right? So infiltration, right, again, is where a non-vesicant makes its way out. I guess I used extravasation as an adjective, but when it infiltrates into the local tissue and it's not a vesicant, it's not going to eat away, it's just going to cause the tissue to be swollen, right? Like normal saline, for instance. It's just going to swell into the hand and get swollen. It's not going to eat away at the tissue. But if it eats away at the tissue, that's called an extravasation, right? And the reason why it's called extravasation because it eat away at the tissue, and the reason why what extravasated was a vesicant, a medication that is high potency, a high osmolarity, a pH that's low or high, and these are some examples. Dextrose is a vesicant when it's greater than how much? 20%. And the reason why we can know that is because of TPN and PPN. It kind of makes sense. So TPN is usually D20 or higher. Okay, and then we got some vasopressors here. We got some things that could cause deterioration of the vessel wall. You hear patients always complaining when they get potassium infusions because it's irritating to the vessel walls. All right, so extravasation and potassium. So we'll just barrel forward. We got like 5 slides left, I think, 6 slides. So we'll barrel forward instead of taking a little break, if that's okay, right? So yeah, so extravasation and potassium. So extravasation means a vesicant has made its way out of the vessel into the surrounding tissue. And what do you do when that happens? Well, you got to slap the patient. That's what you got to do. All right, so you're going to slap them with what? By stopping the medication. That's the priority, because if the vesicant's causing the irritation, we could stop the medication from going in. And L, we're going to leave the IV in place. Well, why do you leave the IV in place? It has medication in it. Well, that's why the next step, A, aspirate. You're going to take the medication out and take as much medication. You might take some of the medication, you might suck it back to the catheter, out into the syringe, right? And the last thing is P, for prepare for the antidote. It's poor practice to use an adjective and a mnemonic, but that's otherwise you call slaughter the patient. Yes?
So before you stop the infusion, do you have to contact the room?
Usually you're going to tell the doctor what you did, right? So I stopped the infusion, I aspirated the medication, and I put some warm compresses on, right? So and they'll let you know, hey, why don't you also give this medication as the antidote, right? Or give this medication also. And those medications are these guys right here, hyaluronidase and phentolamine. Usually phentolamine is given for vasopressors. It blocks the action of the vasopressors, right? And then hyaluronidase is medication that is going to eat away at all the vessel walls, right? I forget what they give it for. I think they give it for lip injections, right? To eat away at the vessel walls, and then it swells with your own inflammatory juices and it makes your lips bigger. Okay, so yeah, so hyaluronidase is also given to eat away at all the tissue and allow the solution to get absorbed quicker. Okay, and we're going to elevate the extremities so that all that fluid can get absorbed as much as possible. All right, and warm compresses usually are to help vasodilate and absorb the solution. Sometimes we give cold compresses. It depends on the medication. And really, when we get to Med-Surg 2, we'll talk more about those, about which one is the right one. Okay, you don't give ice though. Ice is going to not eat away, but macerate the skin. It's going to cause the skin to get super, super red, and it's going to cause the skin to break down further. Okay, so up here in the top right summarizes what we've been talking about. We've got high osmolarity. We got a pH that's lower high. We have a cationic solution. Cationic means it has a really, really high amount of electrolytes in it, such as potassium, right? Potassium is going to pull things next to it. And then we have vasopressors. Vasopressors are going to vasoconstrict, which is not good, but also some vasopressors are directly toxic to that vessel wall. Okay, so potassium itself, we know it hurts, but also we need to know that it can cause the heart to stop, right? If we give too much of it. If you give IV push potassium, they get a bradycardic to PEA to asystole, right? Their heart stops if we give potassium IV push. Okay, so we have to make sure that it's given at a safe rate, right? Also, it'll burn a lot, but ideally we want to give it at a safe rate. So what is that rate? Depends if you have a peripheral line or a central line, right? So if you have a peripheral line, it's 10 MEQs an hour, right, or less. If it's more than 10 MEQs an hour, like 11 to 20, right, then we're going to be giving it via a central line. All right, are we give more than that? Usually not, right? You can get creative and give one centrally, one peripherally, and then as long as you're not doing more than 60 per hour, you're okay. Your heart's not going to stop. But usually we're going to stop it there, right? So you have to it depends on what axis you have, right? So why don't we bolus IV potassium? It's going to stop the heart. That's bad. Okay. So this is an example of a test question here. So we have 5 options, right? We have 5 IV catheters there. And let's say we have to give, what's the example here? We have to give a K-rider, which is just a potassium IV piggyback, right? It's 40 MEQs and 100 cc's, right? Which ones can you infuse at 25 mL an hour? So why A? So you have to do a little bit of light math, right? So what is 40 MEQs in 100 mLs? At 25 an hour, how many MEQs per hour is that? That's 10 MEQs an hour, right? That math doesn't make sense, just you can do the dimensional analysis, but if you think I have 40 MEQs in 100 mLs, that's 10 MEQs for every 25, right? And if I'm doing 25 mLs an hour, that's 10 MEQs an hour, right? What about 50 mLs an hour? That's how many MEQs an hour is that? That's 20 MEQs an hour. So which one of these can get 20 MEQs an hour? Can A get 20 MEQs an hour? No. Can B? What is B? What kind of line is that? That's a midline, right? That is still a peripheral IV. What is C? BIC line, can you give that at 20 MEQs an hour? Yes, it's a peripherally inserted central catheter. That's fine. What about D and E? Can you give that at 20 MEQs an hour? Which ones can be given? Sorry, D and E can. But what about 75 mLs an hour? Can any of these give you 75 mLs an hour? That's definitely more than 20 MEQs an hour, right? Because if there's 20 MEQs and 100 cc's, if I were to do 100 mLs an hour, that's 40 MEQs every hour, right? Yes?
Are we doing math on this?
Light math. Okay. Recognizing, like, is it safe to give or not? Okay. So that's the idea behind potassium, right? And this is a good clinical question, right? I ask it all the time to my students. Is like, how fast you can get this medication? It's like, I'm going to give it at the ordered rate. It says right here, 25 mLs an hour. But your patient's a central line. How fast can you give it? You can give it at 50 mLs an hour if you wanted to. All right, so CLABSIs, the last few complications, right? So CLABSIs is a central line associated bloodstream infection, and this is an iatrogenic hospital-acquired infection, right? What does iatrogenic mean? Oops, right? It means, oh, oops, sorry, right? My bad, right? So iatrogenic means that we can control it. It's our responsibility to fix it. There are some things that the patient brings to the table that makes it difficult, but it's really our job to assess it and take it out, the catheter if they don't need it, and to prevent them from getting a CLABSI in the first place. Has extremely high mortality, right? 12 to 25%. That's 1 in 4 patients that have a central line will die, right? So in this room, we have like 20 people in this room. That means 5 of us will die if you get a central line and you don't take care of it, right? So that's why it's imperative that you take care of it correctly and you assess if someone has it so you can fix it as soon as possible, right? It happens a lot in hospitalized patients. That's why we can convince administration, the hospital people, to buy things for us to prevent the infection from happening, right? Like, why can't you just use the great value Tegaderm from Walmart, right? Or Kirkland brand, look what I got. I got 500 per the package. It's like, that's not going to prevent the infection, right? We have to use sterile gloves, not the nylon ones from Amazon that I got at 5 boxes for 20 bucks, right? I have to use sterile gloves when I'm doing a dressing change. Okay, so cost per infection, so that's also, money speaks a lot. $2 billion per year throughout the whole U.S., but also for each patient in the hospital that gets it, it's about up to $60,000 that's going to cost the hospital and the patient, unfortunately. Okay, so how do you know someone has a CLABSI? They have inflammation. So around the site itself, you notice inflammation. We got drainage. You got purulent drainage coming out. Okay. And it's within it's around the catheter site, right? You got redness. Another fancy word for redness is what? Erythema, okay? And then if it makes its way all the way up into the bloodstream, right? All the way, I'm not sure which way the arm's going, left or right, let's go this way, right? Then it's going to make its way into the central circulation, right? It's going to start to be a bloodstream infection, a CLABSI, right? And that CLABSI will cause central symptoms such as a fever, chills, malaise. That's every single patient gets that when they have an infection. They get febrile, they don't feel good, which is malaise. They get chills, okay? And then we get an SNS response. Well, shoot, why? That makes sense. Fever and inflammation was one of the triggers for an SNS response, right? So that means they could have what kind of EKG finding? Anything fast, right? So so it's a good EKG question. Hey, the patient has this PSVT, and you notice purulent drainage around their right armpit. What do you think caused it, right? And also they have a normal, they've been in the hospital for 3 days or 10 days, and they have all the other things that clue you in that they probably have a CLABSI, okay? And then septic shock, we talk about that more next semester, but that can be the ultimate bad thing that happens with an infection that's out of control, okay, where the blood pressure gets super, super low. All right, long-term catheters. How do you know someone has a long-term catheter with a CLABSI? It's difficult to pull blood out. You can see inflammation along the line, right? And then how do you know someone has a CLABSI? Well, we can do a blood culture. Blood culture means you take a sample of the blood and you see there's bacteria growing in it, right? You grow it across the way right there in the microbiology lab for 24 to 48 hours and you see, oh shoot, there's bacteria growing in this, right? So that's a way to tell if they have a bloodstream infection. Okay, and then how do you know someone has CLABSI? It has to be diagnosed in the lab. If having the redness here is really going to prompt us to request they get a blood culture, request they get further testing. Okay. So what are the causes? It can be separated into what's called intraluminal versus extraluminal. So that means lumen meaning the catheter itself, right? Is it our fault, right, that the port got contaminated, right? Are we using solutions that are potentiating bacteria to grow? All right. Certain things, what do bacteria love? They love stagnant stuff. They like warm stuff. They also like glucose. That's just the fuel for bacteria. So we're giving a dextrose solution that they're high risk for developing a CLABSI. Okay. So in the lumen itself right here, it's our problem. So before we attach a syringe to any kind of lumen, especially a central line, we should be doing what? You should be scrubbing the hub, right? With each hub axis, right? And you're supposed to be with friction. It's not where you just like saturate it and let it sit there, right? It needs to be actual scrubbed, okay? What else? So washing hands is always the right answer, right? You're always going to wash hands before doing anything, right? You explain it to the patient and you're going to put them at a optimal working height, and then you're going to use friction before you access the hub, right? And then is there a bacteriogenic IV solution, like we mentioned, something that's going to grow bacteria, generates bacteria. So high dextrose solutions and also high lipid solutions. So whenever someone's getting something that's lipid-based, what does lipid stand for? What does that mean? It means it has what in it? It means it has fats in it, right? And certain medications have fats. TPN does, right? That's why the lipids are changed more frequently. The TPN line and the lipid line are changed more frequently, right? Because they grow bacteria. Okay. And then what else? So there's also a filter on the TPN line, and that's just it's also to filter out bacteria as well. Okay. And then tubing changes. So there's a great question to ask when we take our IV piggyback quiz, as far as when do I change these tubings? Hey, you just spiked a bag of TPN. When should you change the tubing? Right? Well, I know they're higher risk for infection, so I should change it. How often? Every 24 hours. If something has more than D10, you need to change that tubing every 24 hours. So TPN and PPN, those get changed every 24 hours. Yes? D10, yeah. So if it has D10 or higher, it's 24 hours. The default across the board, though, how often do I change my tubing no matter what, is how often? 96 hours. But the exceptions are these. So every time I have a spike of a piggyback or a fluid or whatever it may be, if it's going to the patient's vein, I have to change it within 4 days, right? The hospital policy at both hospitals is 3 days. It's just like a party. Like you tell your in-laws, you got to get there at 2 o'clock because the clown's coming at 2 o'clock. So you also tell them it's coming, it starts at 1 o'clock, so that you've paid for the clown, right? Anyways, you have so 96 hours is what the CDC says. So, but 3 days is also correct, right? As long as it's within 96 hours, you should be changing the IV tubing. Okay, but what if that tubing has dextrose in it? Then now that changes. Now it's 24 hours, no more than every 24 hours. 25 hours is wrong. 23 hours is correct, right? What about lipids in the tubing? Now it's even more frequent because bacteria will grow in the lipids, right? So that's a 12 hours, right? So that should be changed every 12 hours. And then blood. We'll have a blood lecture for exam 2, and you'll know there also that that's every 4 hours, right? We got to then change the tubing for blood products. Okay, so that's intraluminal. Okay, what else on that? I think that's it. All right. So then extraluminal. So that means outside the ports. It's a problem with nothing inside the lumen or anything, but it's around the site. So for instance, the skin, right? So the skin is bacteria make its way into the atmosphere or the skin, through the skin into the vein, right? So how do we prevent that? Well, we have to do dressing changes. Is this a good dressing right here? No, that needs to be changed. So you change your dressing PRN, but also no matter what, you change it every usually 7 days. Okay, so every 7 days we do a dressing change, right? So every 7, like at Palmdale Hospital, they have central line Sundays. So on Sundays, the central line gets changed no matter what. Okay. So what else? Skin contamination. So the skin has bacteria on it automatically, but that can make its way into the catheter. So like a femoral line, for instance, all those incontinence stools can make their way into that site. So we're going to make sure the dressing is good, but also you got to make sure that they are not incontinent, right, as much as possible. And then CHG bath. So a bath of you're wiping down the whole patient, and you're getting the patient clean of all bacteria. It's an antiseptic, right? And then what else? So it used to be only for pre-op patients, but now we do it for everybody. Every night someone gets a CHG bath, right? And then we got what else? So host factors, like we said, we can do everything we can do, but sometimes the patient has chronic illnesses that puts them at higher risk for infection. They're immunosuppressed, they're on cancer, they have cancer, they're on chemotherapy drugs. They're malnourished, they can't produce the white blood cells, they don't have the proteins to make it, right? They're on TPN, puts you at risk, that's a high risk factor in of itself. Maybe their skin is paper thin, and now their skin can easily tear, especially at the insertion site. And they're in the hospital for a long period of time. That's a problem that can put them at risk for a central line infection. But the best thing you can do is take the line out if they don't need it. Okay, so dressing management are the last two slides right here. All right, so this is an example of I think it's a portacath here. Let's play this video real quick. So our portacath is further down the chest. It's going to make its way up into the subclavian vein. All right, so she's cleaning the site with what? Chlorhexidine. All right, and you want it to dry, right? The drying time is what's called dying time. All right, so the bacteria are screaming in pain right now. What kind of needle is that? That's a Huber needle. Huber needle is what's used to access portacath. So she has, looks like citrate. The citrate locks, right? She has a saline flush there right next to her, against her right arm. You're going to prime the tubing because we don't want to give air into the patient. Okay. And then now she's going to poke the portacath. All right, so she's flushing it, and she's aspirating to make sure there's blood. And then she's going to give the medication, whatever the medication might be. And then we'll put then we make sure it's locked afterwards. Locked with what? Citrate or heparin, right? So she put a tegaderm on it. She didn't put a biopatch, did she? Did she? Okay, cool, good job. All right, so the biopatch is there. A biopatch is a chlorhexidine impregnated sponge. So it has a whole bunch of chlorhexidine in it, and it's going to leak out chlorhexidine so that we can then keep that site where the insertion site is clean and decontaminated, right? So what is this top left one here? What kind of IV is this? That's a PICC line, okay? Could it be a midline? It could. Usually it says, we would probably give you an anatomy picture, show you that it's only going as far as the axilla, right? What about the next one, top right? That's a peripheral IV. What about the next one? That's actually a trick question. Yes, it would be a peripheral line if it was going to a vein, but that's an artery, so that's more Med-Surg03. But you can notice they have what's that little brown square that's next to it, that's underneath the dressing. That's chlorhexidine. It's in a gel form at this point, right? That's an upgrade from the sponge. You know you're working at a good hospital when they have these dressings, right? You're like a Beverly Hills hospital. All right, what about the next one? Middle right. It's a central line of what type? It looks like a portacath, if anything. It's a little bit high for portacath, but it's what do we say? Yep, implanted port. It's a portacath. That's a Huber needle that's accessing it, and that's going to be used. Is that tunneled or non-tunneled? Well, that's a bad question. It's implanted, right? But over here we got what's that bottom left? That's a central line. Yep. Non-tunneled. It's a subclavian central line. Okay, and has a tegaderm patch over tegaderm over that little CHG square. So it's a subclavian triple lumen catheter. What about this one? That's a patient's leg. That's a femoral triple lumen catheter. And triple lumen catheters, we know, are not tunneled. So this is a non-tunneled triple lumen catheter. All right, so dressing changes. Again, you get checked off of this in MedSurg02, unfortunately, but this is where you get taught MedSurg, how to do it in MedSurg01. So it's done how often? Every 7 days, right? And PRN. What if who left the dressing like this? Right? It's like, why is it all peeled back? Like that one in the top left, are you going to change that dressing? Yeah, that dressing needs to be changed, right? Bottom, the bottom right, sorry, the bottom middle, right middle, middle right. I'll show you, just walk over here. All right, so the middle right, that's a great dressing. Why is it great? Because it's also labeled. So we know we need to change it every 7 days, right? So we change it every 7 days. So it's what, 129? So we change it in 7 days, right? Sometimes people don't remember their months and which ones have 30 days and 31 days. So that's why we do like Sundays, guys. Sundays we're changing the dressings. Okay. What else? The other time you might change a dressing is if it's saturated blood. So not only, this isn't really like peeling back, but it's all saturated blood. So that's not good. Why is it not good? Well, A, blood is moist, and that's where bacteria can grow. But also B, it's you can't see the site. Why do you want to see the site? Because a purulent red site is a sign of a CLABSI, right? What about this one right here? What's missing? Top right. Yeah, little CHG, right? Whether it be biopatch or that little square gel, it's missing. What's a biopatch? It's a brand name. I shouldn't use brand names, but biopatch is a chlorhexidine impregnated sponge, right? Has CHG in a sponge, okay? So is this done clean or sterilely when you change a patient's central line? It's done absolutely sterile. So you need sterile gloves. Why do you need a mask? So you don't breathe on your sterile site, right? Also, when you're waiting for the cholesterol to cool, you go, right? No, I'm kidding. So please don't blow to make it dry faster, or wave a tegaderm to make it dry, right? Why is there 2 masks? One for the patients, they don't cough on it and see, what are you doing there, right? So the other thing is, so it's sterile for all central lines. There's no exceptions for this, right? You can just use clean technique for peripheral lines though. What about PICC lines? Do you use sterile or clean technique when you change those? Sterile, because PICC line stands for central catheter, right? Midlines, yes, they're peripheral, but they last for 21 to 30 days. So we're going to do sterile technique with those. That's kind of the little exception. It kind of bleeds over into the central line category. And then supplies needed. What supplies do you need? Why is there measuring tape? Why are we going to have measuring tape on our dressing change every Sunday, especially for a midline or PICC line? Make sure it's what? See if it's migrated out of the patient. Well, on the catheter, I'm not sure if you can see it there, but in other pictures, when you look at the catheter, it has little lines on it, and those are centimeter markings. So that's not the reason. So that's how you know if it's gone in or out. Is a centimeter marking on the line itself. On the tubing, has little marks.
If it has any extravasation.
Good. So if it's extravasated, but it probably wouldn't extravasate if it's a PICC line, right? But what would happen? Why would it cause swelling of the upper arm? Is swelling due to, what's a complication of midlines and PICC lines? Not CLABSI. Well, CLABSI is a correct answer, but it wouldn't cause swelling of that side. It would cause purulence and redness and pain. Complication is DVTs, right? You get a swelling, redness, and pain in that extremity with the catheter. You have DVT as a risk, right? All right, so what else? How do you remove the dressing? So you'll see some nurses use alcohol to remove the tegaderm. That does absolutely nothing. That's just like saunas, right? It doesn't do anything. Yes?
So you're confusing. So you said measure for DVTs or measure for what exactly?
DVTs. You're measuring the arm circumference for DVTs. All right, but you have alcohol in the kit so that we can then, it's sometimes used to remove the stat lock. The stat lock will unadhere from the skin when you use alcohol, but not the tegaderm. Ever know the difference in tegaderm and stat lock? So tegaderm is the clear, transparent dressing right here. And tegaderm is also a brand name, so I shouldn't say that. I should say a semi-permeable transparent membrane dressing, right? But that's a little tegaderm right there. And a stat lock is not pictured, but you can see a stat lock here, right? It keeps the catheter in place, right? It locks in place. Okay? All right, so sterile or clean? It's sterile, right? Do you just peel and go for it? Do you just pull off the dressing? No, you pull it with towards the patient. So right here, we would pull it this way, right? Let's put this guy over here. So if we're taking this dressing off, we would peel it back this way, right? Towards the patient. So distal to proximal, right? What if I pulled it the other way? What would happen? The catheter would come out with it, right? So that's not good, all right? So what else? Be careful of biopatch, right? Sometimes the previous nurse will put the biopatch and they'll tuck it underneath and they'll pull the catheter out with it too, all right? So that's why also these other dressings are a little nicer. All right, so how do you clean the site when you're pulling this, once you have the dressing off, and now we put our sterile gloves on and we're going to clean the site. How do you clean it? Use circles, squares, triangles, stars, it doesn't matter. Whatever shape you feel for that day, like today is a trapezoid kind of day. And all you're going to do is use friction, right? Because the bacteria what they do is they form a little biofilm under here on the site. They're forming a little, like if you haven't brushed your teeth today, all right, if you forgot, right, because you're still worried about the math quiz, you feel your teeth right now, that's biofilm, right? And once you brush your teeth, the biofilm has gone away, right? And your teeth feel nice, pretty clean. You go to the dentist, they feel great, right? So that's the biofilm getting removed, okay? So this biofilm is a permanent, impenetrable force that white blood cells can't get through. So it's like the bacteria literally form a little, force field around themselves, right? So they can proliferate and grow and form purulents, right? So it doesn't matter what shape you use or go in to out to in. What matters is you clean around the site with friction, okay? And what else? You also want to clean the first 6 inches of the catheter because what's going to be underneath. It's like if you clean the whole site, you don't clean the dirty catheter itself. You want to clean the catheter as well. So when you put the dressing on, it's putting the dressing onto a clean catheter and a clean site. Okay. If they don't tolerate chlorhexidine, you can use iodine. All right. Then the next step is using alcohol is another option. Right? And the CHG must dry. It's like you put the CHG down, and then you throw a dressing on it. You got to let it dry. That's what causes the bacteria to literally scream and die in pain. It's like little genocide. It's like millions upon millions of bacteria. What's the question?
So the one in the previous slide that didn't have the chlorhexidine patch, probably was because they had allergies in?
Probably, or they forgot. It's really rare to have chlorhexidine allergy. Right? It's been FDA approved. There's a lot of people have iodine allergies, a lot more frequent than having a chlorhexidine allergy. So a biopatch is an impregnated sponge, right? It's placed over the insertion site. There's it looks like a little Pac-Man, right? And you make sure you don't tuck it underneath, otherwise the next nurse is going to pull out the line. Okay. So what else? And also it's blue to the sky. So we were doing a physical assessment, one of our patients in clinical, and the biopatch is upside down, right? It's like a strong effort, but that's just plastic at the top where it has the company name, right? The CHG is not going to go anywhere, right? So that should be changed. So we have a chlorhexidine. All right, so you replace the biopatch with every 7 days or PRN because the biopatch is a sponge and it will dry out. So we need to get a nice juicy sponge every time. Okay, prevents that biofilm from building up, but it's really our job to scrub it when we're done. All right, so what's there? There we go. All right, so last slide. So we got what's the last procedure, last piece is putting the dressing in place, right? And the dressings now are fancier. That they have not only just the big piece, big tegaderm piece, but it also has belts and a pants, right? So you throw the big piece on it, and you put the catheter through right here, and it's up better up here. So you kind of pull up the legs, like if you ever change a diaper, have the opportunity to change a diaper, you pull up the little leggies, and then you're going to put the pants underneath, and you're going to put it back down, right? And then you're going to secure it with the dressing that has your date and time on it, right? Once you see it once, it'll make sense, right? It has all 3 components all built into this one piece right here. It has the belt there where you put your date, right? So 1/12, whatever today's date is, right? And then it has the pants that is going to go underneath the little legs, okay? So the stat lock doesn't need to be changed every time the dressing's done, but it's there to secure the catheter in place, right? Sometimes they use it in place of sutures, PICC lines especially, but usually it's best practice to suture in the center line. Okay, and if you remove a stat lock, you use the alcohol. If you remove it for the tegaderm, it does nothing, right? And again, we mentioned that those little square gels are just the biopatch that's been blended up and attached to the tegaderm. Okay, and of course, you want to make sure that when you apply the tegaderm, that you put pressure in the middle and you go outward. It's just like when you apply like a decal to your car or something, you want to make sure you don't get any bubbles underneath. Okay, and again, the skin needs to be dry, right? so that it actually adheres properly, and no blowing or kissing or fanning. Okay, all right, and that prevents the skin flora from making its way up to the patient. All right, any questions on central lines? Central lines are not as confusing as EKGs, so it's a nice thing. There's no scribbles to interpret, right? The most interpretation you have to do is like, do I know what is it a central line or not, and is it tunneled or not? All right, well, thank you.